This is a slide that was produced years ago by EGS, and every time I look at this, it looks really pretty and it has nice colors. And I've talked to EGS folks about this. The original slide doesn't have this red mark around it, so I have put this red box. The reason I have done that is because we have significant number of patients who have uncontrolled reflux, and not a lot of them are actually given options for surgical treatment. And that's partially because of prior experience of primary care physicians and GIs with having had patients post-Nissen, having had significant dyspepsia, gas bloat, and inability to vomit. However, especially after June of 2017, now that we have expanded indication for TIF procedure, I believe, in my opinion, that this bracket here needs to move or expand it to the right a bit. The reason for that, as I mentioned earlier, we have now indication to be able to correct even larger anatomical defects. On the other hand, as I showed you earlier, early disease can also have non-anatomic issues or have a normal lower esophageal sphincter. Therefore, you should also be able to provide patients with TIF procedure possibility and giving them an option to correct their reflux, therefore providing significant relief and preventing any further complications. So what's the comparison between Nissen and TIF2 is essentially the same. They have the same manometric appearance, very similar to high pressure zone. This has been an evolution of the TIF procedure over the years to change the technique as well as the devices and bring it to what you have today, which as a head-to-head comparison, there is really no difference technically with being able to offer patients anti-reflux surgery. So the TIF procedure has almost the same technical aspects of laparoscopic type fundoplication, except that this is should be one of the first line in the surgical treatments for gastroesophageal reflux disease. This slide brings home the notion that, again, TIF should be the first and foremost and the surgical treatment for gastroesophageal reflux disease option for many different reasons. Number one, we have significant subjective and objective outcomes showing that TIF actually resolve patients' symptoms of PPIs. There are no de novo dysphagia, bloating, or flatulence reported with TIF procedure. As a matter of fact, patients that did have baseline dysphagia and bloating actually got better. The other aspect here is that you can use TIF to fix a failed Nissen. I'm sure we have a lot of surgeons in the audience that may have done Nissen or may have dealt with Nissen. I'm sure you would be cringing if anybody ever asked you to go back and fix a failed Nissen. So also doing a TIF procedure will not burn your bridges. If you ever need to have another anti-reflux surgery, TIF is not going to affect your lower esophageal area or the area of your hiatal hernia to require you to have significant surgical complications. Therefore, once again, TIF should be the first option in endosurgical treatment of gastroesophageal reflux disease.